Hello everyone. This course is part of the project funded by the European Union and Russian Federation. The name of the project is Promotion of Breast and Colorectal Cancer Prevention Measures in Cross-Border Territories. The name of the course is Fight with Colorectal Cancer. My name is Denis Shimchikas and I work at Day Surgery Center of Republican Klaipėda Hospital and also in Klaipėda University. This is episode number 6 of this course, and I would like to continue my talk about performance measures in colonoscopy in our everyday practice. As a frame for my talk, I will use beautiful guideline published by European Society of Gastrointestinal Endoscopy in year 2017. The authors of this guideline divided pericolonoscopy period into 7 domains, where each domain has one key performance measure and may have one or more minor performance measures. In previous episode, I was talking about the domain named Identification of Pathology, where we discussed extubation or withdrawal of endoscope and looking for lesions like adenomas or other polyps. In this episode, I would like to talk about the management of pathology. What actually we do when we find the lesion. First of all, we adequately describe the polyp morphology. To describe the lesion, we usually use Paris classification. Paris classification was developed with the aim of standardizing the terminology of superficial colorectal lesion morphology. It divided lesions into 2 main groups, polypoid and non-polypoid. All spectrum of lesions is divided into 3 types: Type 1, Type 2, and Type 3. Type 1 may be 1P, 1SP, or 1S. 1P stands for pedunculated, which means polyp has a pedicle. 1SP means subpedunculated. In this case, polyp has a broader surface at the base with healthy mucosa. 1S means sessile. In this case, lesion has the broadest surface at the bases with healthy mucosa compared to previously mentioned lesions. The height of the lesion is usually more than closed biopsy forceps height. Type 2 and Type 3 are flat lesions. Type 2A is flat elevation of mucosa, and the difference between 2A and 1S usually is that the height of the lesion 2A is usually less than closed biopsy forceps height. Type 2B is flat mucosal change. Actually, in this picture, it looks with a depression, but those dots actually should be a bit lower at the surface because this 2B is without a depression. Type 2C is lesion with mucosal depression, and type 3 is excavated through the whole mucosa, muscularis mucosa, and submucosa. So what does guideline say about adequate description of polyp morphology? The Paris classification should be routinely used to describe the morphology of non-pedunculated lesions identified at colonoscopy. The Paris classification is a helpful tool to assess the risk of invasion. When polyp description is adequate, removal of polyps harboring suspicious features is likely to be avoided. Minimum standard is of course unknown and target standard should be 100%. Written colonoscopy reports should include a lesion description based on the Paris classification. Also, we should not forget that there may be mixed type lesions like 2A plus C, flat elevation with central depression, or for example 2A plus 1S, flat elevation with raised broad based nodule. We should describe carefully because different lesions carry different risk of becoming malignancy. After the adequate description with Paris classification, we go to next minor performance measure, advanced imaging assessment. And what do the guidelines say about the advanced imaging assessment and especially about chromandoscopy? It says in patients undergoing removal of colorectal lesions with a depressed component or laterally spreading tumors, conventional or virtual chromandoscopy should be used to improve delineation of the lesion margins and to predict the potential depth of invasion. Why is that important? Because polyps with a depressed component, like 2C, and non-granular or mixed-type laterally spreading tumors harbor a higher risk of submucosal invasion. Such polyps frequently have indistinct borders, therefore better margin delineation is warranted. Improved delineation and prediction of deep invasion may optimize management of these lesions, and target standard should be 100%. The detailed information about advanced imaging for detection and differentiation of colorectal neoplasia is in another guideline published by European Society of Gastrointestinal Endoscopy and updated in year 2019. From broad spectrum of technologies mentioned in these guidelines, we have used or currently are using high definition endoscopy, which actually every endoscopy system has nowadays. We also used high magnification endoscopy or even ultra high magnification endoscopy. For virtual chromandoscopy, we have experience with narrow band imaging, NBI, blue light imaging, BLI, and linked color imaging, LCI, or eye-scan digital contrast. The purpose of these different technologies actually is the same, to differentiate the lesion. But why there are at least few virtual chromandoscopy technologies? The answer is simple, because the owner is different. NBI belongs to Olympus, BLI and LCI to Fujifilm, and iScan belongs to Pentax. All the companies mentioned above also have artificial intelligence technology, which helps us to detect the lesion and to differentiate them as well. Also, there is GI Genius artificial intelligence system, which suits to all the endoscopy systems mentioned above. I'd like to give you a few examples. On the left, we see high definition image, and on the right, we see narrow band image. In all the chroma-endoscopy images systems, usually blood has color black. This is how we can see vessel patterns. In these images, there's example of hyperplastic polyp. The type of polyp is 1S, means sessile polyp. Another example, there's a high definition image and there's narrow band imaging, and this is type Paris type 2A. This is example of adenoma. Another example on the left is high definition picture, and on the right is an NBI image. This is 1 centimeter size early cancer, and this is flat elevation with central depression. And in NBI, we see disrupted vessels, which is a sign of invasion. How to differentiate? To differentiate the lesions using different virtual chroma-endoscopy systems, we have classifications, and all of them usually use the same or similar criteria to describe the lesion. Namely, its color, vessels, surface pattern. And this is an example of NICE classification and PI International Colorectal Endoscopic Classification. This simple classification divides all lesions in 3 types. Type 1, most likely pathology usually is hyperplastic polyp. Type 2, adenomas. And type 3, cancer. When there is lesion similar to hyperplastic polyp, so color usually is same or lighter than background. Vessels are non or isolated lacy vessels may be present coursing across the lesion. Surface patterns, dark or white spots of uniform size or homogeneous absence of pattern. When we have adenoma, usually color is brown relative to background. Vessels are brown, vessels surrounding white structures, and surface patterns are oval, tubular, or branched white structures surrounded by brown vessels. And when we have cancer, it is usually vessels are disrupted or missing, and the surface pattern is amorphous or absent. Another example is high definition image and blue light imaging BLI. Again, vessels look darker than in high definition image. And blue light imaging has its own classification, which is called basic BLI adenoma serrated international classification. And like I mentioned before, the criteria are very similar, namely surface, pit pattern, vessels. And recent studies actually show that both BLI and NBI have a very high diagnostic efficacy and the sensitivity and the specificity of BLI and NBI are actually very similar. Next example is with the third virtual chroma endoscopy system is iScan, and this is a high definition picture and iScan picture. Also, we have tried high definition and high magnification On the left is high definition image and the same polyp with high magnification image. The BLI with high magnification shows very nice vascular pattern which suggests the lesion to be adenoma. We have also tried ultra high magnification. This is high definition picture, BLI view, and ultra high magnification picture. If the endoscopist, for example, suspects cancer, early cancer in polyp, he can magnify that area and to see the image like under the microscope. Artificial intelligence nowadays is very helpful and it helps us in detection. It shows that there is a suspected lesion and it actually does much faster than the eye of endoscopist. What is more, artificial intelligence can help us not only in detecting but also in differentiating the lesions. In this picture you can see BLI image and artificial intelligence says that the lesion in the center, right here, it is most likely neoplastic. Few more examples. The lesion over here, color yellow, suggests us to be neoplastic. Lesion in the center, artificial intelligence says the lesion most likely is neoplastic. This lesion is suggested to be hyperplastic. And very nice picture with adenoma and hyperplastic polyp grow next to each other, and artificial intelligence suggests the lesion in the center is neoplastic and the lesion close to it is hyperplastic. Okay, so we described adequately the polyp. Then we used advanced imaging for assessment. And what we do next is we remove the lesion if it's necessary. So appropriate polypectomy technique is the key performance measure of management of pathology domain. And what do guidelines say about appropriate polypectomy technique? Is adequate resection technique of colorectal polyps includes biopsy forceps removal of polyps less or equal 3 millimeters in size and smear polypectomy for larger polyps. Polyp size estimated by endoscopist has to be included in endoscopy report. Why is that important? Because inappropriate polypectomy technique increases the risk of incomplete polyp removal. And incomplete polyp removal leads to further costs and inconvenience as the examination has to be repeated. Incomplete polyp removal is also considered to contribute to the development of interval colorectal cancers. Minimum suggested standard is more than 80% and target standard is more than 90%. Colonoscopy reports must include information on polyp resection technique. A little bit more information. Incomplete polypectomy is considered the cause for up to 25% of interval cancers. Incomplete resection of polyps from 5 to 20 millimeters in size varies from 6 to 22% among endoscopists. Biopsy forceps resection of polyps 4 to 5 millimeters in size or larger has been shown to be inferior to smear techniques with regard to completeness of resection. Therefore, the appropriate resection technique for colorectal polyps includes biopsy forceps removal of polyps less or equal 3 millimeters in size and smear cold or with diathermy polypectomy for larger polyps. Despite this, in a recent large cohort study, it was demonstrated that even 28% of lesions more than 5 millimeters in size were resected using biopsy forceps instead of a smear technique. Another study, contrary to this, in a large UK study, over 90% of polyps larger than 3 millimeters in size were removed using smear. I'd like to share a few clinical examples. So here we have a high definition view of flat polyp, which was detected by endoscopist and artificial intelligence system. The BLI virtual endoscopy system shows us dark vessels, regular vascular pattern, and the artificial intelligence system suggests us the lesion to be neoplastic, and I think it looks like adenoma. We introduce biopsy forceps. We open them. The size between the branches of biopsy forceps is 8 millimeters. So this polyp is about 3, maybe 4 millimeter size. We remove it with few bites. We wash the defect carefully and we watch the margins of the defect and we conclude that it's a radical excision. And here the message is, if you love your patients, always make a closer look at the margins of the defect, that there would be no remnant of the lesion. So far we talked about removing the lesion with biopsy forceps, and we agreed that we should use biopsy forceps only for the lesions less than 3 millimeters. Actually, less or equal to 3 millimeters. For all other lesions and how to manage them, we have beautiful guideline published in year 2017 by ESGE, and its name is colorectal polypectomy and endoscopic mucosal resection. At this point, I would like to finish episode number 6 and leave the more detailed discussion about polypectomy techniques for the next episode. So in this episode, we talked about the management of pathology, described the lesion, used advanced imaging assessment, and started with appropriate polypectomy technique. And in next episode, I will continue my talk about polypectomy techniques. Thank you very much for your attention.